here today. Gathered this morning to talk about the impact of brain injury country. You may not know the Brain Injury Association of America. We are the voice for people with brain injury. We have the largest network of state affiliates across the country. So with the businesses that you represent, I'm confident that we would have local state affiliates. Many of you may have connections with those already. But we are aware of those whose lives have been impacted with brain injury. Their loved ones, their healthcare providers, their caregivers turn to EIA for support and resources, and we field tens of thousands of calls every year of requests from those looking for support. If you're not familiar with our cause, it's important to know that in terms of scope, it's estimated that over 5 million individuals are living with the effects of permanent brain injury-related disability. But what we all know is that those numbers are really grossly underestimated. For instance, the National Concussion Surveillance System from the Centers for Disease Control and Prevention, their initial pilot found that from adult respondents, that there was as many or as much as 30 times as many compared to statistics, 17 in children. And we also know that 1 in 2 concussions are likely never reported, which is surveillance through things like the reauthorization of the Traumatic Brain Injury Act, the TBI Act. But in our country, we really think of brain injury a little bit more like using a. We think that if you use like a broken leg, you would go and you get a cast, you recuperate, you rest off for a little while, and then you're done. And for many people who sustain a brain injury, they do have full recovery, and that is magnificent. But we also know that there are many that is not the case. In fact, the research actually indicates that brain injury can evolve into a lifelong health condition that not only impairs the brain, but also other organ systems and can persist over a person's lifetime. And we know that it is dynamic, it is not static. So that's why the Brain Injury Association of America, along with our partners, namely the Congressional Brain Injury Taskforce, I know we have representatives from the task force here today, the American Brain Coalition, the National Association of State Head Injury Administrators, are really working to elevate recognition of brain injury as a chronic condition. And so today's speakers really, I believe, will give you that perspective from their own angles and their own involvements in our cause. And so our aim today really is to educate you about the cause. And we've got some things that naturally as we close where you would be able to play a role. But before we do that, we also wanted to pay tribute to a very remarkable individual whom we all know and that we sadly lost a number of weeks ago. And that, of course, is Congressman Bill Pascrell. And I want to acknowledge Dr. Anderson for being here from Mr. Pascrell's office. So we thank you for being here. Mr. Pascrell founded the Congressional Brain Injury Task Force. He was an ally of our cause for many decades and is arguably one of the individuals who was responsible for why we have some of the advances that we have today, particularly from a policy standpoint. But he led the Congressional Brain Injury Task Force most recently with Congressman Don Bacon. I know we have Matthew in Congressman Bacon's office here. Matthew, thank you. And Congressman Bacon has provided a video to acknowledge Mr. Pascrell's contribution and also talk about the role of the Congressional Brain Injury Task Force. So if we can roll that video. We are delighted today to be able to carry forward not only Mr. Pasquale's legacy, but to build on the incredible work of the Congressional Brain Injury Taskforce. And as I mentioned, today's program will illuminate how we can do that together. So I want to start us off by introducing who's panelists today, and that is Paige Melton, who seated to my left. Paige is the current chair of the Brain Injury Association of America, and she has been a caregiver, which I'll let her tell you more of her story. She's been a caregiver now for nearly 21 years from her husband, Robert, who suffered an elusive brain injury in 2002. She leads her own government affairs shop. She has been the Director of Public Affairs for the National Governors Association, Press Secretary to Maryland Governor Shaken, also the Press Secretary to Virginia Lieutenant Governor Don Beyer. Paige started her career actually as a journalist with the United Press International, and she has been a part of the Brain Injury Association of America board since 2020. She's also been an appointee to the Virginia Commonwealth Bureau Trauma Initiative Advisory Board, and she is a graduate of the University of Virginia, as well as serving on the Missouri Veterans Endeavor Board, which provides housing for homeless veterans. And in her spare time, Paige is just joined us here today. So Paige.
Thank you, Rick, so much, and I appreciate all of you all being here. It's a busy day. Thank you for your time. 21 years ago today, it's actually the anniversary of the injury. My husband, Robert Melton, who was a political reporter with the Washington Post, collapsed in our kitchen and his heart stopped. It took a long time to revive him, so long he wasn't expected to survive. But we hung on and he came to 3 days later. Robert had sustained an anoxic brain injury. That's extensive damage from extended loss of oxygen that permanently took his short and long-term memory. He was 46 years old. His injury derailed a well-regarded career and upended the lives of our daughters Nell and Hopi, then ages 18 months and 3 years old. I became a caregiver, and frustration would later make me an advocate. No doctor could predict Robert's recovery, but I was an optimist, and I really believed he'd get better. Life got real, though, very fast, with some of the challenges that are faced by millions of survivors and their families. There's little support to guide survivors and caregivers through a devastating diagnosis. There aren't many reasonable long-term residential treatment options. Insurance coverage is confusing and really strictly vacuum because after the initial hospital stay, there's limited treatment for injuries that are cognitive and physical. As we'll discuss today, brain injuries are often treated as one-time event, as Rick mentioned. Here's an injury, the thinking goes, you'll heal, you'll go back to your life. Robert got the most care of his life in the 2 weeks after that injury when he was in an acute care setting in a hospital. Once it was clear he was going to live, though, while he was unable to talk or even understand who he was, much less recognize his daughters or know me, our insurer said it was time for him to come home. We scrambled, and his employer helped us a great deal, and we cobbled together help at a neurobehavioral facility in the next state, 2 hours away. And when the last of the coverage and our savings were exhausted, he came home, and it wasn't safe for him or for our family with 2 small children. With few supports, he suffered a significant setback that forced him out of our house into a psychiatric floor of a hospital, the only place that would take him in an emergency. His life since then, has been a series of really not ideal residential options, mostly assisted living, where Robert, still physically active and standing 6'5", lives with fragile elderly people. It's only worked because we've had a massive network of people who love and help us care for him, but he's never lived in the right place, and he never got any better after that. His doctors are great. We're very fortunate, but they tend to focus on his heart, or his skin, or his teeth, and I'm screaming inside, what about his brain? In the medical community, his brain injury is a secondary diagnosis, and insurance considers it a closed case. Sadly, though, I've met hundreds of families in the last 2 decades with the same story. You don't have a funding stream for your brain injury. Maybe it's a workers' compensation claim or a lawsuit settlement. We've been told, spend down your assets to qualify for Medicaid and move to a state with a strong Medicaid. Consider a state psychiatric hospital as a place to live because cognitive challenges are somehow being equated with mental health. It's not hard to see how people with brain injuries can end up homeless with nowhere else to go. We have been extremely fortunate as a family. I kept working. We had friends and family nonstop that have continued to help us over 21 years, and I'm forever grateful for that. So many other families have had to make hard choices to get care for their loved ones and to provide for themselves as caregivers at the expense of their jobs, their homes, their relationships, and other family members. So why tell you this story? Robert's experience illustrates, but survivors and caregivers know there's a real disparity in how brain injuries are treated, socially, medically, and financially. That's why we believe that injuries with lingering, ongoing symptoms should be recognized, treated, and covered as chronic conditions, just like diabetes, arthritis, and cancer. Things that can change over months and years and may need a lifetime of care or support. Here's an example in our family, and I talk about this a lot. We have a type 1 diabetic, and one of my daughters has asthma. There are two conditions that are considered chronic and they get unquestioned coverage with drugs, therapy, doctor's visits. Robert, who was easily the most impaired in the family, never got the same consideration, and it's time to change that for millions of survivors who can still get help. Dr. John Corrigan is speaking next. He's made the case for years that brain injury should be recognized as a chronic condition. And David Harrington, who's also speaking, is a passionate provider of the kind of care we love to see more people be able to afford. We're not here today asking you for a handout, just that you help us strategize how brain injuries can be recognized for what they often are, potentially lifelong conditions. Help us find ways to better count the instances of brain injuries that are occurring every day in combat, on playing fields, in elderly homes, on streets and highways, from concussions, falls, strokes, and accidents. Our community of survivors and their families has seen a lot. They are a very tough group. I'm hoping for them and for the next family like ours that society, the medical community, insurers, and policymakers can recognize that an injury to the brain can be a condition for a lifetime. We have a system that will take care of those folks. I'm grateful to the leadership of the Brain Injury Association of America for its advocacy and for organizing today. And we really appreciate and thank you for your time and support for being here to hear our message. Thank you.
Thank you, Paige. So as I mentioned, we wanted you to hear a variety of perspectives today, and so Paige has provided you with that perspective from the lived experience. And now we want you to hear a little bit about what science has to say. And to do that, our next panelist is Dr. John Corrigan. John is the professor in the Department of Physical Medicine and Rehabilitation at Ohio State University. He's the director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. He's also the editor-in-chief for the Journal of Head Trauma Rehabilitation, and Dr. Corrigan is the project director for the Ohio Regional Traumatic Brain Injury Model System and chairs the executive committee of the TBI Model Systems Project. The model systems, if you're not familiar, are a center or collection of 16 centers of excellence around the country that focus on brain injury. He is a member of the Institute of Medicine Board, and he serves on the Neurological and Behavioral Health Subcommittee of the Defense Health Board. He's also provided consultation to the Department of Defense and the Department of Veterans Affairs, and he serves on a number of committees examining the health and well-being of military personnel. Dr. Corrigan has also previously served on the advisory committee for the CDC's National Center on Injury Prevention and the board of directors. He's also on the board for the commission, the accreditation of rehabilitation facilities for PARC, as many of us know it. And on top of all of that, John also serves as the national research director for the Brain Injury Association. And so we're delighted to have John today. And I believe John has some slides, so you can direct your attention.
Well, thank you, Rick, and thank you for that introduction. Some of it is a little dated, but those are all even if I'm not still doing it. So you ask a professor you give him a microphone, you're going to get a lecture. I'm not going to disappoint. I do have some slides. I wanted to share with you just some facts about traumatic brain injury and acquired brain injury. Some of this you're going to know, but I hope there'll be some of this that will be new to you. So some definitions. Acquired brain injury is an injury that happens after birth, and it's not degenerative, meaning dementia. So there are a number of acquired brain injuries. And there you see them. I'm going to be trying to keep up with Denver back there, so thank you, Denver. There's a number of acquired brain injuries, strokes, probably most known, but you can get an acquired brain injury infection from tumors in the brain, some oxygen to the brain, which Age was describing, and then traumatic brain injury. Go ahead next. Traumatic brain injury then is a specific kind of acquired brain injury where the brain has been affected by an external force. Things hit the head has hit something, or there's been such shaking as a result, the brain is moving in the cranial bulb and causing it. As you see here, there are several characteristics of it. They can range from having temporary effects, as Rick mentioned, to permanent. A concussion is a traumatic brain injury. I really want to say that again. We prefer the word concussion over traumatic brain injury, but a concussion is a traumatic brain injury. And all traumatic brain injuries vary greatly in severity. I want to show you, go ahead. I want to show you what that looks like. So on a continuum from least severe to most severe, that continuum is defined by how much the brain's function is disrupted when this force occurs. Something, whatever. The least amount of disruption is the person experiences being dazed or confused, or they may have a gap in their memory. The next most severe disturbance is there's actual loss of consciousness. The person died. And in the most severe again, go ahead, remember, is coma. In coma, not only are you knocked out, there's also just some reflexive responses in the brain. Now, we have talked for years about mild, moderate, severe traumatic brain injury. Would have lined them up with these ways in which the brain's disturbed early on. Go ahead, Denver. But unfortunately, the mild TBI we define as including all of that, where there's just being dazed, confused, or gap in memory, as well as some of those injuries that result in loss of consciousness. Next, Denver. A moderate traumatic brain injury then is where the rest of those that result in loss of consciousness. And then the severe traumatic brain injury includes most of those that result in coma. Now, along this continuum, there are a couple really important benchmarks. One of the things I sometimes say is if I said to you, my name is John Corrigan and I have a traumatic brain injury, I actually told you more by my name, implying my gender identity. And I've told you I have a traumatic brain injury because it could have been anywhere in this continuum. And it's a very different outcome anywhere on the continuum. Go ahead, Denver. But one benchmark that's worth noting, showing us you there. The first one is if there's any loss of consciousness. If loss of consciousness, it's going to be more likely to have some kind of residual or more lasting effect, more permanent. And then if that loss, hold on just a second, you can go back. If that loss of consciousness lasts for more than 30 minutes, then there's a pretty high likelihood, very high likelihood that there'll be some residual effects. Now, it may not be full-fledged disability, but it's just going to affect a person's, how they think. Maybe their cognitive endurance, maybe their other ways that they express themselves. So it'll be there even if it's not full-fledged disability. But of course, some people full-fledged. So go ahead. There are other factors, though, that play into the risk for having these chronic effects, just the initial severity. One is cumulative effects. Go ahead. And cumulative effects, we have multiple, even multiple mild traumatic brain injury. We don't know if it's the actual number that makes the difference or if it's the spacing. If you have another one before the last one has fully recovered, you may have a worse effect. And so far, actually, there's evidence for both the number and the spacing negative. Go ahead, Denver. On aging, there's developmental, where children, a less severe injury in childhood carry effects into adulthood. So it's a developmental interaction. And we see something similar at the other end of the age. For older adults, sometimes a mild traumatic brain injury is kind of a sentinel event, which is them into not being able to be. And then finally, kind of similar to the cumulative effects, if you have some other thing that's affecting your brain, and then you add in a traumatic brain injury, it's going to be worse. So all of these things raise the you're hurrying me along, Deborah, thank you. All of these things affect the likelihood that there's going to be persistent long-term or chronic effects. So a little bit of a detour here, because this is always worth saying. That's that particularly in traumatic brain injury and some of the other acquired brain injuries, including, for instance, hypoxia, the fingerprint is that it affects the frontal areas of the brain, no matter what other area. Even if the blow comes back to the head, there's bruising there. There's reasons why then the frontal areas also are affected. And this occurs, it's a mechanical thing. What happens is, some kind of force is played upon the head, and brain moves within the cranial ball. And for the most part, that's fine. There's a gelatinous kind of cushion, there's a leathery outer covering of the brain, and there's most of the interior part of the skull is smooth. If you advance. However, in the frontal area and on the left there, you're looking from the top down. In the frontal area, there are these bony ridges. And if there's enough jiggling of the brain within the cranial ball, then the tissue is going to scrape across those bony ridges. And then, as shown there on the right, is likely to cause bruising or contusion, sometimes even bleeds, how it bleeds in those frontal areas. And so that's why no matter where the blow comes, you're more likely to get it. Go ahead and so autopsies done in the 50s, series of autopsies or later with advanced imaging, looking at loss of a tissue 1 year after an injury. Every study that's looked at has said the frontal areas are the most vulnerable, the most likely to be. There's another dynamic here, and it has to do with some of the connections, particularly from the midbrain up into the front. And go ahead. And those connections are really susceptible to the same jiggling. And so again, it's mechanical. It's like it's very dense. The tissue is compressed in there, and if you cause it to jerk or move suddenly, some tissue moves at a different rate. And it causes stretching or tearing some of these connections from the midbrain into the frontal areas. Not portrayed here, but also the connections that go from the right side of the brain to the left side. They are more vulnerable to this stretching and tearing. And so when we use advanced techniques to look at where the damage is, what we see is that it's highly concentrated in these frontal areas. So these are two different mechanical sources of greater focus on the frontal areas. Go ahead. And we don't do phrenology. We don't do phrenology anymore. But different parts of the brain do subserve different functions that we do. And one of the things I would say is that as humans, if we're going to pick a part of the brain to injure, the frontal area should not be. They are unique. There's many uniquenesses to us as humans that among all the mammals, our frontal areas are the largest proportionately in terms of the whole frame of the brain. They develop the most from infancy into early adulthood. Most of the change in the brain, greatest proportion, is happening in the frontal areas. Go ahead. And so many of, back up just a second. There we go. Along the left there, these are many of the abilities, capabilities that are highly dependent. And while all traumatic brain injuries don't disrupt all of these or totally stop people from having all these abilities, but in terms of thinking skills and behavior, think about, how important many of these things are for just getting along, just being successful. And frankly, it's a double jeopardy. That having weaknesses in some of these areas are more likely to get you into trouble and make it harder to get out of that trouble. So if I'm more vulnerable to developing a substance use disorder, and then the treatment that's needed that will be harder for me to be successful in if I have medically person side. It's a double jeopardy. I'm just focusing on these. Obviously, brain injury also causes motor disturbances, motor weaknesses, causes sensory disturbances. But I wanted to get this part about kind of the cognitive and emotional aspects, just because I don't think it's always understood about traumatic brain injury. And I didn't show it here, but it is the same frontal areas more susceptible to brain injuries as well, which happen when your heart stops. It also happens with overdose. It also happens if you were strangled as part of it. So we see a lot of that. Okay. Yes. So kind of back to the mainstream here. Sorry for that detour. What do we mean when we talk about a chronic health condition, chronic disease? You'd think this is about having a chronic concept, but go ahead. It is not, and back up just a second there. Burnell and Howard did a study where they looked at all the different definitions of chronic disease or chronic health condition, and they came to the conclusion that you need to watch the definition you're using vary quite a bit. Now you can. So, for instance, the WHO, their definition talks about it being a long duration but slow progression. They're complex. They result from a multitude of factors. Go ahead and advance. CDC's definition talks about it being at least a year. There are actually some definitions that are used shorter. Just for 3 months. That's pretty short. But CDC talks about a year, and it's something that needs ongoing medical attention or limits activities of daily. They emphasize 7 diseases. They mention others, but they emphasize 7 that were advanced. Their sister agency, the Centers for Medicaid and Medicare Services, lists. This says 22. Actually, if you count all the different subsets, et cetera, it's probably up a little closer to 30 different chronic diseases. I've highlighted their stroke because it's an acquired brain injury and traumatic brain injuries, which actually were only added to this list this past year. For many years, CMS did not recognize injury as a chronic condition. What do you think about that? So go ahead. So if you go back to Burnell and Howard, it's one more time. They suggested that we take a simpler approach to what is a chronic disease condition, that it's continuing or occurring again and again for a long time, like advance. But they would exclude a broken leg along this reference, because broken legs, you have some period of recovery, but then it's going to be stable. It's not changing. But for instance, as I pointed out, low back pain is something that is going to be variable and dynamic. So why are we saying that traumatic brain injury is a chronic condition? More than a decade ago, with our colleague Flora Hammond, we go ahead and advance. We published a paper, go ahead and advance, that was about that used data from the GBI model systems that Rick mentioned, where we look at people, and this is a longitudinal data set following folks from injury to the rest of their life. And we looked at year two after their injury, back to year one, said, did they improve? Did they decline? Did they stay the same? Did the same for year 5 versus year 2, year 10 versus year 5, year 15 versus year 10. And what you see there is that, you know, in the red or pink, that you have folks declining, or in the green, folks improving. Down the middle in blue are those who stayed the same. Well, if you assume that traumatic brain injury was a stable condition, you'd be wrong. 50% of this study. That indeed stable was not the most common. What was less common is shame. Go ahead and advance. Very recently, with Dr. Hammond and the colleagues, we updated this data. Go ahead. Now that the TBML systems has grown, we have quite a few more cases, and we now have out to 30 years. You know, it's small out there, there's 160 people, but you're getting the idea. It's the same dynamic. It's not, the blue is less than half of folks are stable as we look at these 5-year periods. Now, if you know something about the brain injury research world, you know that the TBML systems is about people whose injury is severe enough that they require rehabilitation and that they are people who have moderate and severe trauma. So, you know, some say, well, isn't this just about moderate and severe and advanced? There's another longitudinal study called the TRACK TBI study that is now looked out over 7 years, and in a similar way. Go ahead. And here, just those with mild traumatic brain injury, earlier, just those with mild, we're seeing the same dynamic. This is just out to 7 years, it's not to 30 yet, some time before the data will come in. But even out at 7 years, amongst folks with mild traumatic brain injuries, it's only half that are showing stability over time. Other, that's why we think we're in advance. So going back to this graph, go ahead and advance. Think about just this part of the spectrum. Those who have a loss of consciousness, or the initial injury severity. What I'm showing you here is the prevalence amongst adults in the US of various chronic conditions. And what you see there for traumatic brain injury is that some 18% of adults have had at least one traumatic brain injury with loss of consciousness. This is only those whose injury was severe enough to be loss of consciousness. It's not that less severe part of the brain. And it's 18%. And see how that compares to other conditions. Now, another unique thing about that, just being there in red, is that that's the only estimate that did not come from the CDC. All of these other estimates are available on the CDC website of the prevalence of these chronic conditions. But because traumatic brain injury hasn't been thought of as a chronic condition, and they don't have a similar estimate. This 18% is taken from a recent meta-analysis done in the Journal of Neuroepidemiology, very large study. We have other studies that put it around 20%, 22%, 19%. So we think that's pretty much in that range for loss of consciousness. But at 18%, and you throw in stroke there, which is another acquired brain injury, and we don't even have estimates for like anoxia or some of the other acquired brain injuries. You know, it's quite clear that this condition is not getting the attention that these other chronic conditions get. Even if you say, okay, you know, it's only half that aren't stable. So go ahead and advance. If we just cut that bar in half, now look at it, it still is way out of proportion in terms of the amount of resources that are being directed to understand brain injury as a chronic condition versus those beside. I mean, are we getting 2/3 of what's being used in diabetes? Are we getting 50% more than what the resources going into heart disease? No, down the line, nowhere near getting the resources. And so as a result, a very basic question is, so why is it dynamic? What's causing the change over time that we see in 30 years after an injury? There are theories about that. You know, maybe it's inflammation, or maybe it's some micro damage to very small damage to blood vessels. We don't know. The kind of research that needs to be done so we can understand the chronic aspects of brain injury just haven't been done yet. We know a lot less than we do about all these other conditions here. So I'm just going to wrap up by mentioning a few kind of pragmatic issues that are very of concern to us in terms of this recognition. Go ahead and advance. The first is that just in healthcare generally, brain injury is thought of more like the broken leg. So, if, for instance, there's some indication that folks who've had an earlier life traumatic brain injury may be more susceptible to falls a whole decade earlier than other adults. Well, as a general practitioner, be alerting me to that, and thinking about it, and getting me to think. A general practitioner may not even know I had severe traumatic brain 10 years ago or 20 years ago. But I'll tell you, if I'd had an earlier diagnosis of stroke, I probably would have known it, or an earlier diagnosis of MS, they would know it. They won't know. And if you make the assumption that it's going to be stable, you're going to miss other things. For instance, we know that some of the deficits that you have early on that get better, early in the injury, that with normal aging, they may start to decline. But they can be refreshed with a short course of therapy. So, maybe I had some speech problems earlier. I'm very good at it. But now, 20 years later, I'm in my 50s. I'm starting to have some speech production issues. A short course of speech language pathology speech therapy could make a difference. But if I'm not thinking about it, the condition's not thinking about it, it's not going to. So we need to change the whole zeitgeist. We'll be thinking about brain injuries. So go back just one. So the second I've already kind of mentioned, but when we recognize something as a chronic condition, we put a lot more resources into public health approach. Education of providers, education. That's not happening. Or anything. Most require brain. And then finally, go ahead, Bender. Even in a very practical way, if we just look at Medicare and Medicaid, there are a lot of protections and additional resources for people who have a condition who are covered under those programs. For instance, if you have 2 or more chronic conditions, there are some Medicare services that are additional Medicare services available to brain injury doesn't. In Medicaid, in many of our state programs, particularly our managed care programs, there are extra protections and extra services for individuals who conditions. The companies have to commit to those where they're bidding for the contract, that they'll provide an extra case management, that they'll maybe have expanded therapy services that would help individuals with a condition. You don't qualify. And something like case management is something that would be really useful if having some of those funnel-related things. So I'm going to stop there. Some too lectury. I hope you heard something we haven't heard before. But we think there's a very strong case with even what we're doing.
Dr. Thank you. Before we go to our next panelist, I'm curious, for those in the room, how many of you, either from personal experience or that of a loved one, have been exposed to or impacted by brain injury anywhere on the continuum of the health program? Most of you in the room, right? So I hope that you, based on your own personal experience, I hope it resonates with what you're hearing in terms of why BIA is so focused on recognizing that getting a head injury is something you go home and you sleep off. And so to really bring us to our almost perspective on the topic today, we heard from the caregiver and lived experience, you heard from the science, and now I want you to hear from the healthcare provider perspective. And to do that, I want to introduce David Harrington sitting to my right. David is the vice chair for BIA's board of directors, and he has worked in the field of post-acute brain injury rehabilitation since 1993. He's held a variety of positions, including therapist. He's been a clinical case manager, a quality manager, director of operations, and he is currently the president and chief executive for the Center for Neuroskills, which provides intensive post-acute community-based brain injury rehabilitation. He is by training an occupational therapist. He received his MBA from Cal State University in Bakersfield. He is a certified brain injury specialist trainer, program with the Brain Injury Association of America. Dave was also an adjunct instructor at the School of Business at California State University of Bakersfield, where he teaches operations management, business ethics, business data analysis, organization behavior, university management. Okay.
Well, thank you, Rick. I cannot tell you what an honor it is to be here with all of you today to talk about something that I am absolutely passionate about and it's important for society. As Dr. Corrigan said, brain injury is very complex, and given the heterogeneity of this injury, there's no brain injury that's alike. And in my 30 years of working in brain injury rehab, I have yet to find one injury that's the same as the other. And it's not only catastrophic to the individual, but it's catastrophic to the entire family as well. And it's so unlike a knee replacement or a knee injury, where it's going to be episodic in nature, time limited, very specific, to where therapy caps of 20 would be appropriate. Brain injury is not that way. As Dr. Corrigan said, it extends far beyond what 20 visits do. Now, it requires a comprehensive interdisciplinary team of both medical and rehabilitative specialists. And I can tell you over the years, when you get the right specialists, the right time to treat this very specialized injury, we can remove, at least loosen the tether of disability and dependency for that person and allow them to resume their life and their role. Now, though I have been around for about 20, 30 years in brain injury rehab, the gaps in the system have affected my family as well. Not only with my mother, who I lost to brain cancer, but to my uncle. And I want to just share his story a little bit to juxtapose what's potential versus what often happens. My uncle, just about 3 years ago, had a stroke, and he was taken to the hospital where he was remaining there for 2 days. And my aunt, who is a 100-pound woman, very small, not very strong, and also epileptic, would have to take care of my uncle. He was discharged from the hospital only after 2 days of having the stroke and did not receive any type of therapy or therapeutic assessment and did not go through the continuum of care that I will perseverate on over the next several minutes. He was discharged home, and when he was in the restroom, he fell, lost his balance, and hit his head on the side of the bathtub, sustaining a significant traumatic brain injury. And when he was re-hospitalized due to that injury, of course, I got very involved. And I was very disappointed that one day when I was watching my uncle, he was confused, he was agitated. I didn't know where he was, didn't know, he was yelling out, striking at people. He had to be restrained. And clearly not a person who was able to go to the next level of care. But the physician came in and said, the insurance company and I decided your uncle needs to go to a skilled nursing facility, which number one, is not a specialist in brain injury. Number two, does not provide the intensity and density of therapy that my uncle needed in that time. They did not have the adequate support. And the physician said after about a week, he'll probably go home to home. I said he will not. He will go to acute rehab or an inpatient rehab facility where they're going to provide the level of care that he needs, the specialty that he needs. And after that, he's going to come to Center for Neuroskills, a post-acute residential rehabilitation facility where we're going to do more rehab with. And that's what happened. And had I not intervened that day, he would have lost his job. He would not have been able to keep his house. He probably would have lost his marriage. And quite frankly, I believe he would have lost his life. But I think that that is the story that most people experience because their loved ones don't have a healthcare professional guiding them through the system and through the continuum. And what I'd like to do in my few minutes that I have with you is just to highlight the continuum of care and what you should expect for your family and what we should expect in our society. And so the services that are available to brain injury survivors, you can see the graphic very simplistic up on the screen. That is the continuum of care. And of course, we have the emergency services and the acute care that most of us are aware of. Those are the two services my uncle received. But after a person has a brain injury, the next level would be to go to the acute rehab or the inpatient rehabilitation, where their medical needs are still going to be met, but they will be introduced to more intense therapy, 3 hours of therapy, OT, PT, speech therapy, recreational therapy, whatever that patient needs. And when that time comes, it would be appropriate then for them to come to a post-acute neurological residential rehabilitation program like the Center for Neuro Skills, where I'm the CEO. And in this type of setting, this is where you will find a comprehensive interdisciplinary team of physical therapy, occupational therapy, speech therapy, education therapy, counseling, nursing, recreation therapy, that all envelop the patient, their injury, and their individual needs so that they can provide the rehab so that person can resume their role and their independence. But also that person needs a case manager to then guide the team, to be able to project what that outcome is, to be the liaison to the insurance company, to the attorneys, to the family, to be that stakeholder manager. Because this type of injury is so complex that you need a team working together all in the same direction. Now, once they leave that inpatient rehab facility, it's possible to go to a day treatment program. So rather than getting 4 to 6 hours of therapy that's inpatient, maybe it's 4 to 6 hours of therapy on an outpatient basis. And then transition or titrate down to where they may need an hour or two of PT or speech therapy, depending on what that person needs. Now, of course, at that point, home health would be fine. And perhaps for a lot of our patients, or some of our patients, I would say, they're going to need long-term support. This is a chronic issue. A lot of times the disabilities and dependency go on long-term, and so they need some assisted living or support. But if you juxtapose what I just shared with you in terms of that patient journey, contrasted to what my uncle received or was going to receive, you can see that there are major gaps in the system. So, in terms of best practices, there are some best practices that I want you to be aware of for your own family member and what you can affect in this nation. First of all, early and accurate identification of brain injury. Dr. Corrigan talked about that not all brain injuries are diagnosed. To be able to have some of these blood markers are very important. To be able to identify that, and also for us to be able to identify the proper journey through the care system that the patient needs. And to be enveloped, again, by that comprehensive interdisciplinary team that are specialists in brain injury. There was about 5 years I worked as a hand therapist, outpatient orthopedics. So, you see a flexor tendon transposition, with the take one tendon to the next. We didn't see brain injury in those settings. Why? Because we dealt with orthopedic issues. This is why we need the neurospecialists to deal with the neuro injuries. And to be able to have that comprehensive team, and it's not only affecting the physical function, but it's affecting the cognitive function, what a person can remember, what processing speed, how they carry information from minute to minutes to hours to days. And not only that, but also what are they doing in terms of the psychological aspects, the adjustment to disability, the loss of their role, and enveloping the family in that process is absolutely critical. And a lot of our patients, because of their brain injuries, especially the frontal lobe injuries that Dr. Corrigan talked about, our patients are also often disinhibited, they act out, and to be able to have that behavioral support is absolutely critical. And then, of course, social support and medical support. I hope I'm really highlighting and underscoring the need for comprehensive care that cannot be fragmented in an outpatient setting. The individual needs individualized treatment because every brain injury is unique and every person is unique. And they will present their cases so separately. And so that individualized treatment is important. Also family involvement because it affects the entire family, also that longer term. Now, some of the gaps that I see as a provider would be the inaccurate diagnoses, the lack of assessments, and to be able to fund research that will help to identify other biomarkers and ways of testing whether someone has an injury or not. but also the guidelines in terms of treating brain injury. When I worked in orthopedics, when we had that flexor tendon transposition, there were 5 different protocols. The surgeon would say, I want this protocol, and within 12 weeks, you know, agree. And we don't have those guidelines well defined in brain injury rehab. I've experienced fragmented care because of the heterogeneity of the injury. Also, the lack of access to specialized care. Give you another stat that's very personal to center for neuroskills. A lot of people leave the hospital with 2 ICD-10 codes. On average, when our patients come to Center for Neuroskills, they have up to 27 ICD-10 codes that we're trying to manage. It's significant. And so they need that comprehensive team. And as Dr. Corrigan said, research is absolutely critical for this space. The knowledge of neuroscience is expanding so quickly, and this is what we need to leverage in order to make a difference with people and their families with brain injury. To have that long-term support is also important. A lot of our patients are limited by benefits, capped therapy, whereas a lot of our patients are going to need that ongoing support. And they may not need rehab for a long time, but they need some type of support someplace. The healthcare industry is also going documentation heavy, which is an extreme burden on providers. And rather than providers providing therapy, they're spending a lot more time and a lot more money documenting and writing reports. Those are the burdens and the gaps that we see. So we have an opportunity to advance rehabilitation and the care for people with traumatic and acquired brain injury. This complex and catastrophic nature of this injury requires specialized intervention from a comprehensive team with the proper intensity and density of treatment. And this requires not only CMS, but our commercial payers to treat this on par with the complexity of this disease. Thank you for letting me come talk to you today.
So again, I hope that gives you a perspective of the continuum and why we are focused on brain injury, recognizing brain injury as a chronic condition. Now, here we come to the part where you can help. So there are 3 things that we want to leave you with. So number 1, if the offices that you're representing, if your boss is not currently a member of the Congressional Brain Injury Task Force, please join the Congressional Brain Injury Task Force. Dr. Anderson, and again in the back, Mr. Pascal's office has been a point of contact. If you have an interest, if your office has an interest in joining, please reach out to her directly. Number 2, the TBI reauthorization is passed out of the House. We have Senate version of the bill. There's some differences. We're looking for support to certainly be reconciling those differences in conference, but be looking to support getting that bill reauthorized across the finish line. So again, we ask for your support. And that certainly want to recognize Senator Mullins. And I believe we might have some Senate Health staff and Senator Casey's office also in the room. So I want to thank you for your leadership on the Senate side. And then lastly, Brain Injury Awareness Day on Capitol Hill. We were here in force this past March. We're back again this coming March in conjunction with Brain Injury Awareness Month. The date will be March 5th. We will be bringing constituents from around the country. This past year, we had approximately 300 that were with us. We're hoping to have more than that to come and visit with each of you from your respective districts. And so once you mark your calendars for March 5th, this meeting will be back for that. So at this point, we do want to open it up for those of you who are representing, in particular, those of you who are representing, I know we've got a number of others in the room, but I want to start with those of you who are representing member offices. What questions would you like to ask, and anything that you see that was not addressed? Yeah, I think we'll ask Dr. Corrigan to respond to that, and John, if you wouldn't mind repeating the question for those.
So the question was about when a coma is induced versus when it's a direct result of force in the brain. So we do a lot. We induce coma. Transport somebody, get them to a place safely where we can be sometimes agitated behavior, etc. that comes from being comatose. Induced coma does you have to kind of take into account that it's not as bad. You have induced it, means the brain hasn't suffered some of the same impact. Same thing happened at the. So it's very effective medical procedure, typically short term. And it does, you can't judge severity by the, when it's been induced versus when it's happened. Was that responsive? Well, so the induced comas typically, I mean, when we use that term medically, it's something there's been an out-use area. It's part of the crisis there. Sometimes, oh, but it's just part of the variable. So, but it's after there's been something else that's happened, it's caused the brain to.
One more question. Any other questions from the member offices or Jay?
Well, first of all, thank you all for sharing. Appreciate it. See on this issue. Yeah, Jay from Senator Mullins' office. I guess my question, maybe Dave, would you be willing to share like a success story of like making it through the continuum of care, kind of how you kind of laid it up there, and how we like you already spoke to how that, but I know your uncle was in that continuum. It sounds like, but folks who like any stories from CNS to folks who've been in.
Yes. So Jay, thank you very much, and thank Senator Mullen as well. So the question is, are there examples that's of other patients other than me who really went through the continuum and had a success story? I am so inspired every single day when I go to 7 locations in Texas to see the patients make the progress that they make. You can go to neuroskills.com, you get a lot of patient videos that are very cool. But it's typical for us for when a patient comes to see us, we often get our referrals from the acute care or the acute rehab or the inpatient rehab facilities. There are times, and I feel like the OS are under fire, where sometimes that care is being circumvented for several different reasons, and we'll get them from the med surg order. And so we now have to be more sophisticated in our medical care, whereas before that was handled upstream of the continuum. What is not good is when people go home, much like my uncle, and they get re-injured. So that care continuum is very important. I would say that the timing that they come to us is important. For example, there are a lot of our patients who were injured on the job, and they will go home. And so there's a long space between the incident and the treatment that they get. And during that time, there may be some maladaptive plasticity that occurs for behavior or movement patterns are well ingrained. And we almost have to do re-engineering to undo those bad patterns before we apply the right neuroplasticity. And so that time, that latency between injury and getting access to care really does make a difference. So our patients who will come through our program often are in walkers or wheelchairs. They will be in walking. And there are times where everybody progresses at a different pace. Many of them have cognitive problems, processing speed, speech and language issues, difficulty coordinating their hands. I think what's important in rehab is that we're not only addressing the cognition, the physical function, the psychosocial aspect, but applying it to their real life and being able to translate this outside the clinic, such as doing lab evaluations where people are going back. We do power tool assessments if they're a contractor, they're going back to work, or going back to driving, and applying those real life skills in the therapeutic setting that you're not going to get in other levels of care. They can't do it. And so the majority of our patients do go home, the great majority, and most of them also go back to work. So rehab does make a difference in work capacity.
I think you got a question. I think we have one more in the back.
Yeah. It's actually in neurological journals of way of their intellectual things that estimates actually 50% of people that are homeless have brain injuries. And that's supposedly half of that because they get them on which they are after that they have to understand because there's not enough support without a doubt. And there's another thing, scriptures I mentioned later, everyone's talking to either the cup of tea. I've also talked to people with a disability and brain injury that way you're in a big abuse situation. And it's really hard also having a brain injury and not really understanding yourself, the way what went wrong. It's fantastic for people to look on the outside, but to the person inside and you have no idea what's going on, it's just kind of awful without a doubt. And but there's also many forms of support which COVID won't through. And a person that in a very bad situation, and actually occasionally that's happened and targeted me in my situation, voicing good people, but it's really important to know support people, especially to kindness physical activity too. But it's also worse if you don't know what's wrong, things that I think educational is therapy, it's physical therapy, you name it. But sometimes people can fall for the effects of these things. Because cognitive, if you don't have like the organizational skills, which yes, people are organized generally, honestly, whatever. But when you're diagnosed with that, you don't have a sort of cognitive recreation therapist, not a behavioral therapist. But a cognitive recreation therapist, all good practice. We'll do 5 things once, nothing's.
Well, Abby, thank you for sharing your story. Others to talk with you afterwards. Thank you.
And it's how like you had to go.
I'm famous. I'm almost off the off. It's thank you all. It's an amazing panel. I had a question about besides the problem of that, those people that see you're taking care of what financial obstacle they're seeing capital complex needed care and like how to like government programs like dedicated like care assist that.
So really great. It's highly variable across the United States. So in terms of Medicare, they don't pay for post-acute residential rehabilitation. Get a Medicare license, they won't pay for a level of care. So if you don't have Medicare, it's unfortunate. There are many commercial payers out there that work really well. Blue Cross Blue Shield of Texas is one of them. There is some bills out there that allow for cognitive rehabilitation. And it allows the insurance companies to give us more treatment. They recognize cognitive rehab as a part of a simple part of a person's program. You contrast that with other payers that I won't mention. They often will deny care and saying that cognitive rehab is experimental, is what we are told. That if a person has behavioral issues, it's a social problem. And those are the reasons for denying the care. We often get reimbursed at our level of care under the major medical benefits. So there has to be a medical reason for them to be here, but not so much the rehabilitative aspect. So once a person leaves the inpatient rehab facility to get to a specialized post-acute residential rehab facility like the Center for Neuro Skills, there aren't benefits. And that really limits the access to our level.
I would just add that in addition to there not being enough services acutely, then there also aren't enough services given 5 years out or 10. When somebody could benefit from a refresher of doing some PT now to improve my balance again, or to improve. So many companies don't, insurance companies won't see that as medically necessary, and so will deny, having the recovery. Medicare is better about it more recently, though.
It's also in the disabilities.
Then we'll take one more question.
So we're doing a lot of work in that space right now. Various sources of social improvement. They have an effect in terms of the injury happening at all. And And so, folks affected by various, associated determinants are more likely to have injuries, but then they affect services they get, the likelihood of getting into some of these specialized services initially, and then the longer term. As good as folks who, are from marginalized communities or SES, yeah, or disadvantaged neighborhoods. So, and even we're looking at studies like how she can, depression, other things, and it does. Lower income, urban areas, less treatment. So there's a lot in that situation now. There's tremendous. So no different than any other patient, except that we already are behind the 8 ball, and now we.
And I would just say, we were extremely fortunate, and I was able to go back to work and take care of that. But if you start out and you're on the margin and you have a catastrophic situation like this, and no matter what the cause is, I mean, you can, lose your home, you can end up homeless, it splits up marriages, yeah, I mean, folks in the prison, I mean, it is the disparity is so sharp in this situation.
Well, thank you all. We know that you have busy dockets. You have probably a pile of other issues when you get back to your respective offices. And I hope, though, that this has shed some light for you on the importance of brain injury and the importance of the treatment and what we're going to be focused on. And we hope to visit with you further about the topic. We also still have plenty of food. If you don't take something with you for lunch, I'm going to have to put it in our suitcase, get back to the plane and take it home. Oh, well, then we're really in trouble. So please eat up and enjoy your breakfast. Thank you.